hello for those who have joined. It's Kelsey Gallant from the PSP Central Office. If it's okay with everyone, we're just going to give it one more minute. I think there might be at least 5 or so more logging in, so we're all ready to go, but just hang tight with us for a minute if you can. Thank you.
Did this screen turn off?
No, it's still green. Do you have it on your laptop? Can you see the weather?
Yeah.
What is it showing?
Oh, no. That's a clear reason why.
Hi guys, it's Kelsey again. Are there 2 of you out there together by any chance watching this? Because I see we can just hear you. That's all. I should let you know. Call in user 1 and 6. If you didn't know, we can all hear you. You might want to mute yourself.
Oh, yeah, that's us.
Okay, well, it's 2 minutes after, so I think we'll get started. Hello, everyone. It's Kelsey Gallant speaking from the Practice Support Central Office. I'm under the alias of Christina Thomas today for the webinar. So if you need to ask a question using the chat feature, please feel free to type to me. Or as usual, we're amenable to questions throughout the presentation. We've got with us today David Trottier from TELUS Health Osler. Sorry, that's a new way of saying this, so I'm just trying to make sure I got it right. David was with Osler Systems for a long time, very knowledgeable about the Osler EMR, and we did some collaborative work with them around some of our PSP modules, as many of you know, and so we've just, we're eager to get a presentation to you guys on the tools for the adult mental health and child youth mental health. So David's with us today to show you those. We have an hour and a half. We may not need it. That seems to be the trend lately. We've kind of been maybe overbooking. So maybe I'll get a little bit better with being able to benchmark the time it takes. But anyhow, if we can finish early, we will. David will start us off, and as usual, you're welcome to ask questions as he goes, or you can type a question to myself on the chat feature. I'll moderate that throughout. We're recording the webinar today, so you'll have the opportunity to go back and access it if you need to, just to refresh your memory. And I think that is all. Without any further ado, I'll turn it over to David to start us off.
Great, thank you. Thanks, Kelsey. Thanks very much, and thanks for helping get this set up. As Kelsey said, we are, as of about a month ago, a member of the TELUS Health family of products. The associated products in BC that you might have already seen or will see are Wolf and MedAccess. So we're the 3rd leg in the stool in terms of EMRs available in BC. So I'm just going to take you on a very brief PowerPoint demonstration, really to sort of explain the kind of overall philosophy. I don't mean in Osler or TELUS Health, but in the mental health tools. And then I will dive into the software and show you what we've done, the forms we've done, and how they can be accessed. So basically, in Practice Manager, which is the name of our application, that hasn't changed, mental health tools are clearly separated into child and youth and adult resources. They're not blended together. As you know, there's far more child and youth resources, or there appears to be, than there is adult ones in terms of forms and questionnaires and things, because, of course, there's parents involved, there's teachers involved, so there's definitely more information flow with patients under the age of 19. All the forms, we create our forms in Word, not in a PDF format. We populate them not only with demographic data, but sometimes with clinical data. Some of them are available in what we call encounter template format. There's pros and cons to both, but most of our clients currently use the Word forms. and I'll show you those. And reports identify and track patients with ongoing mental health issue. With our system, it's important to separate patients that would need a mental health care plan and would need ongoing support from people that what we call have transitory issues. If somebody comes in to see their family physician and says, I'm a little depressed, and has a chat with the physician, and they develop some kind of strategy to resolve it, and the physician doesn't feel the need to create a mental health care plan because it looks like it's a very short-term thing, those are distinguished from people that actually do need a mental health care plan and are going to require more ongoing treatment, perhaps referrals, and perhaps some more information gathering. And the reason they have to be separated is that actually the ICD-9 codes that are used for mental health really don't distinguish always between, again, a transitory issue or a long-term issue. Anxiety, depression doesn't have anxiety, depression in brackets long-term or transitory. It just says anxiety and depression. So it's important that we use other things other than diagnostic codes to identify people that would require an extended mental health care plan and the associated billing and service codes that you can bill with that. As you see at the top there, it says the 3 Ts. We basically have to tag the mental health patients first of all, and then obviously they have to be treated through the process, the algorithms that have been provided, and then we have to make sure they're tracked so there can be the appropriate follow-up. So we call that the 3 Ts. Again, as I said just now, it's important to separate patients with transitory mental health issues from those with mental health issues that appear to be more ongoing. And this is sometimes difficult because, of course, the physician always doesn't know when they first see a patient how long this mental health issue is going to extend. Hopefully it'll be short, but not always. And in those situations, often filling out a mental health care plan has some value. And as I said previously, diagnostic codes can't easily separate transitory and extended mental health patients. And the extended mental health patients do require a mental health care plan. And we do provide a Word document that drops in the appropriate medications and problems that relate to this problem. And then at the bottom here it says there needs to be an identifier in the chart which tags the patient as having a mental health care plan, and I'll show you where we put that identifier. Treating, again, there's a variety of forms and templates you can use to measure a patient's mental health issues and, of course, proceed accordingly. There's also billing incentives available, as you know, that support the care of mental health people. So when a physician runs out of the requisite 4 counseling sessions that family doctors are allowed, there's another code they can use and extend it out and add 4 more into the equation. And we track those things, tell you how many you've got left to bill if that's important to you. So you, again, you get paid appropriately for the care that you're giving. And then again, tracking mental health patients, we use something called a custom report to track them based on the fact that they've got a mental health care plan and or perhaps a PHQ-9 questionnaire. And again, we also generate the reports, as I just mentioned, based on the billing availability. So again, a quick summary, the 3 Ts, tag, treat, and track, are the ways we identify and follow these patients through the system. We have fillable Word forms, which I'm about to show you, which cover all of the different options and questionnaires, and we have a series of reports that track people along the continuum, hopefully till the issue is being resolved and the doctor can close the plan, so to speak. So let me open up the program now. I'm just going to go down here, just opening up Practice Manager to just the schedule, that's all, today's schedule for a few doctors. So if I open up the chart here for Martha Smith, if I just double click here, it'll open up her chart, okay? And the key to deciding whether a patient is a long-term mental health patient or, you know, not a transitory one, long-term may be unfair, is something in the condition. Our system, one of the important components of it is what we call conditions, or you might call it current problems, whatever you like. And if you put in here a mental health related condition, which this happens to be, what triggers the patient to be a long-term mental health patient is just simply MHP in the comment field. That's what triggers it. As I mentioned before, this depressive disorder can be used for transitory situations where it's not involved. So to somehow narrow down the identification, we add this MHP to the comment. And that triggers other things to happen when that's in there. And of course, if the patient, if the doctor establishes this during the first visit, and then the patient comes back, let's say a week later, and says, you know, the clouds have lifted, I'm feeling much better, I don't think I need further treatment, it was just transitory, then the doctor can simply open this up and remove this mental health plan from here, and then the patient is no longer part of that protocol, and they move on hopefully with their lives. When you are in the encounter area, which you can get to from here, there are some encounters here. You can see the scared ones here and the mental health questionnaire and those sort of things in here under what we call encounters. But most of our clients actually use Word documents to follow the progress of a mental health patient. So you see down here I've got a folder called Mental Health, and it's split into adult and child and youth. So if I follow the adult one, you see there's a drop down here with the forms for adult mental health, right? And I've got the adult mental health algorithm here. I'll open it up to show you. Okay, this is not a fillable form, obviously. It's got the algorithm here, which a doctor can look at, okay, and they can determine what, perhaps they start with a questionnaire, take the patient through a series of questions, score it, and based on those scores, they direct them into one program or another. There are the links down here. Kelsey mentioned there might be some minor issues with the links, but all of these actual forms and resources are all created as Word documents anyway, so you don't really have to actually click on the links from here. And in fact, it wouldn't be beneficial in that it wouldn't then auto-populate the various forms with the diagnostic and demographic information. So I'm not going to save that. So if I want to fill out, for example, a PHQ-9 on Martha Smith, which would be probably a pretty standard start, okay? So I've got a PHQ-9 right here, okay? So if I click on it, okay, it'll open it up, and you can see the PHQ-9, and I can start scoring this. I can, you know, ask the questions as a physician, and I start to score the questionnaire. I'll go down here. And then when I get down here, the system will automatically calculate the score. Okay, so it's a 22, and I can tick the box at the bottom here. And then I can go and save this in the patient's chart. So I can save it. Okay, and what I do in there to track the score is actually in the note field, I put the score equals 22. And if I want, I can even create a task, in other words, a reminder that would go out to the staff or even to myself that I need to recall this patient, let's say, in the next month or so. So I can save this, and the task comes up, and I can add a note here if I want and close the task. So now inside the patient chart, I've got the PHQ-9, and if I want, I can go back to my algorithm and look at it. But let's say that I decide that I want to enroll Martha in, let's say I want to enroll her in the Bounce Back program, for argument's sake, okay? So I've got my Bounce Back physician referral here. If I click on this, it opens it up, and you can see it populates with various things here. It does not populate the PHQ-9 score, so I'm going to type it in here, and then I'm going to tick various boxes here as relevant, and just use the tick box. It's got my name and address as the physician down here, and then I can either print this out, or if I want, I can fax it directly to the Bounce Back program, whatever I choose to do. And again, I can save this inside the patient's chart. Obviously, I want to save all of these forms inside the patient's chart. So I can use the drop down here, and I'll just do mental health. Oops, the daisy. And I will call this Bounce Back referral. And I'll save it in the chart. So at this point, I've made a decision that this person needs a mental health care plan. I've referred them out. I've done the questionnaire. I've established the score is quite high. It requires some treatment that may be beyond my capability or my time or my resources. So I've referred this patient out. So now I need to create the mental health care plan. And again, I can do it through here, through the mental health and adult. And in fact, the care plan I put up at the very top. So I can click on this and it opens up the care plan. And what it does is, I saw the care plan there for a second, and then it brings this up and it says, what current medications are relatable to this illness? You can put whatever you want in here. So if I put Prozac and nitroglycerin for whatever reason, and I put that the person is depressed and they have essential hypertension, if that's important, and I click OK, then the form comes up and you can see it's dropped the active problems in here, and it's dropped the medications in here, okay? And so then here, I just choose from the drop-down, whatever it happens to be. Okay, I just have to click on this and choose the drop-down. Not sure what that is. And stressors. Okay. Okay, so I've done all that here. You see, I've added, so to speak, all of these up. Then I can fill these in here, whichever way I want, and reassessment will be in 3 weeks or whatever it happens to be. I can do 3 weeks and then, or whatever, and then I can save this in the chart again, the same way I save the other things. And I'll show you where they are in a second. That's the mental health care plan, and I'll go save. So if I go into the DI docs here and I go into the mental health folder here, you can see I've got my bounce back, I've got my bounce back referral, I've got my mental health care plan. Let me just show the dates here. Here are the three. My questionnaire, my bounce back referral, and my mental health care plan are all here. And I sent a task out to my MOA, my staff, to rebook the patient in a month's time. All of the forms in here, if I've taken the wrong approach in terms of the bounce back, it's something else, they're all in here. So why don't we go through these forms and have a look at them, and just to make sure you understand how they work. So I'm going to click on here. Okay, now some of these are informational rather than like a questionnaire where I tick boxes. So this is some of them in here. What I've tried to do, and not always successfully, is I've tried to separate them out a little bit into forms that you fill out and forms that are just informational. With the child and youth, it's more important because there's so many more of them. So here are all the child and youth forms, and then I've got the information-only ones, which are often just handouts you give to the child, if it's probably a youth, or the parent, or the teacher, or some other caregiver, which they can use as a reference point in helping treat the patient when they're not obviously with the physician. Okay? So let me go back to the adult ones. So let's do the symptom checklist here. So that's more of a one to fill out, right? Of course, any one of these can be printed, because in some cases you'll actually give them to the adult to take away with them, or go to the waiting room, or they'll stay in the exam room and you'll leave and give them 10 minutes to fill it out. And other ones they'll take home with them in some cases, and then they'll bring them back at a later visit or at the next visit. Go back here again. Okay, AMA links to core resources. That's basically the same as this one. It's just the bottom part of that. There's something called an appreciation exercise. Okay. Again, these are simply Word documents. You can edit them. You can write stuff on them. If you want, they can be populated with the patient's name, although we don't always do that because of privacy issues, but you certainly can do that. And so here's the Beck, okay, depression one. Again, it'll always drop in things like name, age, and gender or sex. Some things it won't drop in because that information perhaps isn't in the system, and it'll always put in the current date where that is relevant. Go back here again. The bounce back, sorry, go ahead. The bounce back we already looked at because we filled it out for Martha, so I'll look at the brief action planning one. Okay, here's a flow chart. Okay, So this is really more informational as opposed to something that you fill out. So again, you can, in here, if you find this is too long, and some physicians do, it can be broken into other folders. We're reluctant to do that with mental health, I think probably because we don't know enough about it as EMR folks. And so what we do is we sit down with our clients and we say, okay, how do you want to break this down? Do you mind having a list with 20 items in it, which may be more difficult to eyeball when you're trying to get something up, or do you want to break it into different categories of mental health or different processes? You tell us whichever way you want to do it. So it can be broken into smaller chunks depending on whether they want to break it down that way. The other thing that some people like, and it's also easy to do, obviously, with Word, is sometimes you can cascade them together. So you might say, why don't you put the PHQ-9 and put the mental health care template right after it in the same document? So you fill out the PHQ-9, or you put the PHQ-9 and the bounce back and the mental health all together in one kind of order list. And that can be done as well. You can blend things together if you want. If you want to, you know you'll always be filling out things more than one form in sequence, you can run them all together into a single sequence if you want. And again, some people ask for that as well. Okay, so this is a mental health. This is the involuntary admission one. And again, you see it's pre-filled where appropriate with the fields from the EMR. Okay, go down here. Okay, so the GAD-7 is quite a common one. You've probably all seen this a few times. So there's the GAD-7 screening one. Okay, where you can fill in the numbers and calculate the score. The score gets calculated down here, and then you can score that or put that in your records. Here. This is a geriatric one. So this is a depression scale, short form. Okay. Again, some of these you would print out and give to the patient to do themselves. We have one site that has tried to hand the patient, not tried to, they have handed the patient an iPad and had them fill this out with their finger touching the screen instead of actually printing it out and then having to scan it back in again. It's doable. I don't necessarily recommend it because there's more possibility of error, but it certainly is doable if they want. Usually we make the boxes bigger because people's fingers are a little bit larger, and consequently they need a little more space. But most people, if it's something for a patient to fill out, would actually do it with them, or they would print it out, let them fill it out on paper, and then scan it back in again. So we're down to, well, that's just the warrant for the involuntary. That's an apprehension of patient. Okay. Again, maybe the provincial forms like this could be separated out into a separate folder. They're probably, hopefully, not used as often. But again, the organization is entirely up to the physician and the staff. It can be done in every way you want. Okay. Okay, so this is the MOCA one. Okay. Mood scale. The optimal mental health pathway. Okay, that's you can see it's dropped in a few things there. That's the welcome to the Mental Health and Addictive Services Client Questionnaire. PHQ-9 we've looked at already. I won't go that one again. Okay, that's for psych medications. Now, ordinarily, you would fill that out, not here, you'd fill it out from the medication area. So when you prescribe the medication, it'll actually drop it automatically into the box here. So this one you ordinarily wouldn't fill out from this area, you'd fill it out again from when you prescribe the medication directly. Here's the problem list action plan. That's pretty basic stuff. Okay. I think there's one more. It's called the problem list. Okay. So those are the adult mental health forms. By that I mean Word documents. Let me just quickly show you here. If I look at a PHQ-9 as an encounter rather than as a form, it looks like this, okay? So you see here during the last 2 weeks, have you been bothered by any of these? And you just choose from the drop-downs what numbers they are for each of the 9 questions. And then at the bottom you total it, and it's got a follow-up question down at the bottom here where you select from these drop-downs. Is there a right or wrong way to do this? Should I use this one rather than the Word document? There's no real right or wrong. There's no benefit other than, in my opinion, it's nice to have all of your mental health forms in here, in one space where you can see them all together. If you need to refer the patient off to another healthcare professional, you can easily attach all these to whatever referral letter you write or you create. So there is some benefit from my perspective to having all of the forms for this particular condition all in one place. But certainly it's not, there's nothing wrong with using an encounter to fill those things out instead. It works perfectly well. Yes, go ahead.
Sorry, you said to go to, this is Joe from BCH. You said to go to the Plan G, you have to go through prescriptions. Would that, when that's filled out, does that actually end up in the documents as well? Or does that end up somewhere else in prescriptions?
It's a good question. No, it ends up in the documents as well.
Okay.
That's right. So when you create a prescription in here, what could happen? I'm just going to open this up. And I actually, in here, what we're finding more and more likely is you see, rather than I have the word depression in here, and I have different drugs that treat depression. So I've got depression 1 is Prozac, depression 2 is Effexor, depression 3 is Wellbutrin. If I choose any one of these, okay, and I go save, okay, and there's interaction, that's okay. You scroll and let me show this up here. Here's my, let's see, here's my Prozac. If I right click and go print special authority, I can do it right from here. Okay, and I can choose my special authority, whatever it is. I don't know which one it is here. And let me just choose, doesn't really matter. And then it opens up the form. This is not the right form, and it auto-populates the drug in here. And then when you go and save this, then it can save it actually to the same location, the mental health folder as the other ones. Okay? So it's actually better doing it from the medication area because then it auto-populates with the medication that you've chosen for that particular condition, and then, as you pointed out, saves it in the same place as all the other mental health forms. Okay, so you've got sort of a nice, neat package there. Okay. Let me just close this. I just want to show you something else before I start with the child and youth. If I go up here to reports and custom reports, I have a series of reports here that we've created, and again, we can drop these in any of our clients' offices. So I've got here mental health adults current, okay, and these are patients, these are mental health patients, okay. Now, by definition, these people have a mental health plan, and by that I mean, if you remember what I mentioned a few minutes ago, under their conditions, I have put MHP. And the idea of this is to distinguish them from the transitory mental health patients who probably don't require a plan at this point. Not probably, almost certainly don't, because if there's some doubt, usually a physician should fill out a mental health plan. That's the idea, but of course that's their judgment. So these people have in their conditions a mental health related condition, and the physician or somebody has put MHP in the comment field for that plan. So that's what distinguishes these people. So right now I've got 9 people on my adult mental health plan. Okay, and I can right-click on any one of these and open up their chart right from here, go look at the documents or whatever I want to do. Okay, here's Martha Smith, the one we were just looking at. If I open up her chart, I can go to DI Docs, and if I'm in mental health, I can see all the forms that I filled out and the questionnaires for Martha Smith. Of course, if Martha hopefully gets through this condition and is no longer requiring of a mental health plan, then I can simply remove this from here and save this. I'd probably mark this as it's now resolved, and I go save. It's no longer in here, and then she would drop off this form because she no longer requires a mental health plan or an ongoing treatment. Okay, so those 3 letters are the trigger for other things. Whether they're in there or not in there is what will generate a variety of reports. So when I've got, again, mental health adults with a care plan document, takes it one stage further, and what it says basically is these people actually have documents in the care plan. It doesn't mean that they still have a mental health issue, but it means that they've got a care plan. I can look at people with a PHQ-9, and you see the scores here as well, okay? And then I can go to the children and youth one, which shows me a list of my children and youth that have got certain codes and certain distinguishing factors. Before I leave here, I want to show you the billing ones. So I've got people with mental health with counseling visits remaining this year. So it shows me the people and the visits remaining this year. And then it shows me people who are eligible for the 14043. Those are the ones that have used up all the counseling visits. And in fact, because of that and because they've got a mental health care plan and certain other criteria, they're eligible for those extra codes that allow essentially more counseling visits than the standard 4 that a physician usually has. Okay, let me go in and have a look at a child here. It actually doesn't matter, and maybe this is not necessarily a positive, it doesn't matter whether I've got a patient of the appropriate age in here, I can still access the adult and child forms, okay? So it doesn't block out the adult forms when I'm in a child's chart or vice versa. So you obviously have to be aware of the age of your patient when you're choosing particular forms. I know this patient is 9 years old. Her birth date's 2007, and so I know she's a child, and she would be the child forms be the ones that she would have, okay? So what I would probably do with a child to start with is, well, actually, I'd probably do it this way instead. Let me just try it this way. I'm just going to go into encounters, and I'm going to go here, and I'm going to try the child and youth and mental health screening questions. Now, this is a template, okay, and you can see it here. The benefit of this is it kind of gives me a pathway into the next step. So I go through this and I read about the family history and so on, and then I mark some of these down, and depending on what I mark here, then I get redirected to the various different, whether it's CADS or SCARED or SNAP or one of those, it actually directs me to the appropriate resource. So this is an encounter. It's also a form as well, but often physicians actually fill this out in here. They go through it, and as soon as they get the answer they want or the answer they're expecting perhaps, then they can go up here to document right from inside the encounter and go to mental health and child and youth and choose the appropriate one in here. Okay, so there is an encounter here called, again, the child and youth mental health screening questions. It's a little bit long-winded. But let me show you the documents. Okay, now the child and youth has been broken out because there's so many more, and there is ones called information only. For example, let's look at this one called getting up in the morning, okay? And this is one a physician might give to a parent guardian, or if it's a teenager, might give it to the teen as well, and it's basically got some explanations around sleep problems and how to maybe resolve them, or how to maybe make them go away. You notice it asked me to save that. Ordinarily, I wouldn't save handouts. Some people do. We have physicians who save the handouts, and that for them indicates that they've given the patient the handout, which is totally appropriate. But handouts sometimes aren't saved, like obviously questionnaires or encounters or things like that. But we try, because there's so many more options with child and youth, to separate out the information ones from the other ones. So there is an algorithm for the child and youth as well. Okay, here's the algorithm right here, and here are the links here. I'm not sure, Kelsey, whether those are all valid as well. But again, we have taken all these and turned them into Word documents. So there's really no reason for an Osler client to be looking through here to print them out. And the reason we made Word documents, of course, is one, sometimes links don't work. That happens sometimes. And two, with a Word document, we can auto-populate part of the form to make it easier for the physician and the patient and their guardians to fill it out.
David, it's Rob here from Interior Health. Can I ask a question? What are the links again? Is that the algorithm links?
That's right, yeah. So I'll show you.
It's Kelsey. Yeah, it's Kelsey. Those are the links that are actually embedded and linked from the PSP website. We were just alerted actually by Yogita's team early this week on about some links, the fidelities and links that weren't working, and so Erin Picard from PSP Central is working on that, and we're going to be making those fixes. And then some of the vendors link directly from our website, and some don't. So it may or may not affect accessing forms from various algorithms. But as David's mentioning, and in most cases, those would not be discrete data forms. So presumably the physician would be using the forms as embedded parts of the template. But just to be aware, that's what happened. And it also could be, it probably of more concern is if you're looking at our algorithm on the website right now. Right now they're fixed. If you were looking at our algorithm on the website before yesterday, you may have noticed there were some links in the adult mental health algorithm that weren't working. Those have now been fixed.
So will they be fixed in Osler then?
Yeah, well, again, what I was saying is that, Rob, you don't need to actually use these because we've created forms for all these. So, in fact, going to the link is not to your benefit because it won't auto-populate the form then with the patient information in Osler. A link is just basically opening up a new web page, and you'd have to fill out the demographic data manually if it's a form or print it out, whereas these have all been replicated. Now, I say all, but I don't want to be called out on it. There may be ones that we haven't done. That's part of why we're doing this. But I think almost all of these have been replicated as Word documents. So, for example, you see here the scared child link here. Well, you don't need to use that there because under the new document here, under mental health and child and youth, we've got the scared child right here. And the benefit of it
so it's already in two places. It's already there, what you're showing now, and it's also on the algorithm, which they might have on their desktop. So I'm wondering if those links aren't even necessary there.
They probably aren't. Again,
yeah,
it's their. Sorry, go ahead, Kelsey.
Could be redundant. Some people like to access the algorithm to refer to it. And that would mostly be to reference. I wouldn't imagine they'd be using the links. It's just that the ask was there, rather than having to exit out of the template. If I want to have a look at the algorithm, can it be there? The point is good. Maybe we could look at just eliminating the links. But for now, it's just a standard copy of the algorithm because some people do like to access the algorithm from within the EMR just to reference it.
From within the EMR. Okay, that makes sense.
Yeah.
What some people might do, Rob, is they actually might open this up. And as Kelsey says, because they want to kind of draw back to it, they may just minimize it and not actually close it and then open up other ones in here, whatever it happens to be. But they know then that they can always refer back to the algorithm by just clicking here and looking back at it. So there may be some benefit to that.
Workflow-wise, they should be getting the forms from the EMR Word documents or the encounter, right?
I would agree with you.
So that it's saved on the patient chart. Yeah.
Definitely, yes.
Yeah, But they may want to glance back at this from time to time as they work through the problems, and so they can leave this open at the bottom if they choose to. Okay.
Yeah. Okay.
So let's go through some of these documents. Child and youth. So the youth care plan up at the top here. There's a family care plan and a professional care plan. So the family care plan, again, it drops in. You can choose medications and conditions and drop them in there. So if the patient is on medications, it would have dropped them in here as well. And you can see this here, and you can enter a date for a reassessment if you want. Okay, so we want to reassess the patient in a week or a month or whatever. I can choose a date there. And again, this can be saved in the chart like the adult ones. If you go save here, okay, you can choose it goes in the mental health folder, and you can choose a name up here and save it in the chart. And again, it would all be in that mental health folder. We call it MH simply for privacy reasons. Mental health, unfortunately, despite what Bell had going on yesterday all day, which was wonderful, still has a bit of a stigma, and so we tend to short things out a little bit to be a little bit more discreet about it, that's all. Because in our system, if you have any items in a folder, it actually shows that there's something in the folder even if you don't go in there. So again, because there's still a little bit of a stigma, we choose to call it MH rather than mental health. That's not mandatory. A doctor can call it mental health or whatever they want. There's no criteria. That's just what we've chosen to do in our demo system, that's all. Child and youth. Okay, so let's look at the youth care plan for the professional. And again, this is very similar to the plan for the adults. Right, so we've got the different disorders here we can choose in the drop down. Okay, no different than the other one, and it drops in anxiety disorder and so on. Okay, all of those go in there, and so on. So it's the same kind of form as the other ones, and then you can fill this out in here, and then you tick a box down here if you want to see the patient again in so many weeks or months or whatever. And then again, you would save this in the chart as a care plan. I'm not going to say these just to essentially save time, but the process is just the same. Let's go to the child and youth, and we'll look at the CADRA teacher assessment form. Now this presumably would be printable unless you had the teacher in the room. Even if you did, the teacher would want to fill this out, and then it would come back to you, and it would be scanned into the system and stored again in that mental health, the MH folder there. And the CBIS skills. Okay. Again, this is probably something that you would fill it out and give it to the youth, and then they would, it's like a little diary they fill out every day to see whether there's certain days that trigger certain things, or whether in fact their ongoing issues are across all days and hours of the day. And
David, this is Anna here from Nanaimo.
Hello.
Is the CBIS included in the adult mental health module or section?
Is the what included? Sorry.
Oh, sorry, the CBIS. Yeah, the CBIS.
Okay, let's have a look. Is it in the child one and not in the adult one? Yeah. So, I mean, any of these, Anna, can be copied between either one of them. It doesn't look like it is from what I can tell, because it would be under the C's here. So should that one be in the adult one as well?
Yes, it's quite a large document, but it's really comprehensive in terms of resources for patients.
Is there a CBIS skills adult as well?
Yes.
Or is it the same? Okay, so we're missing the form is what you're saying.
There is, yeah, David, check the SharePoint site. If it's not there, let me know, but it should be there. It's definitely, it's one of the more popular ones.
Okay, thank you for letting me know. We'll add it in there for sure.
Thanks, David.
It might link from the algorithm too, if the link's correct.
It might, but we'll make it as a Word form and populate it. Well, actually, there's no population actually in this one, right? It's just basically a printout. So yeah, we'll figure that out. But we'll make it into a Word form. That's just been our yes, go ahead.
Sorry, it's Anna again. The one advantage to having this as a PDF is that you can search through it more quickly. Okay. Because it is quite a large document, so you can search through by bookmarks or section by section. This one is only 8 pages. The adult version is 100 and something.
Many pages, yeah.
Yeah.
Very lengthy.
So there are lots of advantages to having it as the PDF. I don't know if there.
So is a Word document not as searchable as a PDF?
Well, I mean, I know you can like Control F, but the bookmarks are very helpful.
I just did find here, and I can type in whatever I want, right? Yeah, so it does. Okay. So only 2 there. Okay, so let's see PDF. Okay, I'll make a note of that. Thank you.
Thanks.
Yeah, I think we're on, we looked at that one, we're on this one. Again, some minor population here, but again, obviously needs to be filled out by somebody. Do you know, you'd know better than I do, but do most physicians print these out and fill them out on paper and then scan them back in, or do they fill them out on the computers themselves? I don't have a good sense of that.
It's Kelsey, and I'm just tooting the horn for the ideal workflow. We would be strongly encouraging people for all sorts of reasons to be doing things electronically, but I'm aware that certainly people would fill them in on paper and then scan them back in. I'm curious to hear, though, from the group what they're seeing, if they're seeing a trend either way, or if it's a 50-50 split, or what that looks like for them.
Hi, this is Joe from BCH. My experience is that before the tools got into the EMR, the doctors were adamant that they won't use them unless they're in the EMR. And so when we just completed a child and youth mental health module in one of our regions, the actual workflow around using some of them, because they're lengthy in the EMR, all of a sudden got them thinking about that immediate need that they had before wasn't as whatever. So a lot of times they're giving the tool out and getting the patients to fill it in and then scanning it because it's lengthy, because an alternative workflow would be the doctor asking the question or having somebody else ask the questions and filling it out. So this is what, like the more lengthier ones are being printed out, scanned back in.
Ideally, in the future, there would be some kind of mechanism for, like, either, I don't know, I've seen in other jurisdictions and stuff, some really cool things around like kiosks in waiting rooms, or, you know, the workflow is sort of embedded that the forms are sent electronically to the patient in advance, or all sorts of things that kind of help generate the form in advance of the visit so that the physician isn't doing it, but that it is coming back electronically.
Right, I agree, yeah. And that's where things like iPads and stuff, and as you say, kiosks have value for sure. My impression is that I don't think, at least I can only speak for our clients, and I'm not in a day-to-day contact with them, that, again, I think as your colleague said, the short forms they're quite willing to fill out on here, but if it gets too lengthy and they're looking at their watch and their waiting room's got 7 people in it, that they may say, print it out and I'll leave you here, I'm going to go next door and talk to the next patient, and I'll come back and gather the paper up from you. So it's a process for sure.
Absolutely, and I think that as you're having those conversations around workflow, one of the things that that might be kind of a good conversation would just be, for not all of the forms you're going to want to monitor over time, but some of the key ones like the PHQ-9 and things like that you may want to look at over time. Right. It would be great if it was embedded as discrete data.
I agree, and that one particularly, there's really no excuse to print that one out. I mean, it takes. It's 9 numbers and then a total is all it is, right? And 1 tick box. So there's really no real benefit in printing that one out, to be honest with you. At least not my
thought about, through a patient portal, sending it out to patients, and then it's
yeah,
Their chart basically, and then filled in and sent back to the chart kind of idea. Is there like that kind of thought in the future?
Certainly no reason why you couldn't, right? I don't see any reason why not. I don't know whether there's, the short answer is I don't know. Technically, there's no reason why that couldn't be done.
Yeah.
The mechanism to do it, I really don't know.
That was the workflow I was alluding to. Like you see that at, progressive clinics in private clinics in the States and things like that. All of this stuff is facilitated through portals and things like that. So I'm sure we're getting there.
Yeah. So again, I'm just going through these forms. I've already marked one that we don't have, obviously. So if anything else triggers by something I am looking at, sorry. This is the craft screening one. Okay. Now, I'm just trying to think. I'm thinking more of youth, really, like, could this be emailed to them on a smartphone, which they all have, as we do, and could they fill it out on their smartphone and then just email it back to the doctor? Again, I don't know. I'm just not sure. I'm not sure what the protocol is for that. So here's the CADS one, which is again one of the more common ones. Okay. Okay, and there's the CADS scoring, and I'm not sure why we've put this stuff in there, but I think maybe Kelsey, you asked us to do that.
Mm-hmm.
That's just the CAD scoring broken out. That should be in the information only. And these are some of the letters requesting for school supports. That would, I don't think that was one of your documents. Maybe it was. Maybe it's one that we added. I'm not sure. Might be one from you.
David, is this where somewhere like the local MCFD referral form and all that could be added or embedded or whatever? Is this where that would be if the doctors were wanting to look for something for a local document to refer to, let's say like the MCFD?
I would think so, yeah. And again, that may be something where you break out local resources. So, if you're in a certain area of the province and there's forms that are unique to your area, you might have a subfolder there, or you might take some of these out, right? But yeah, again, as you can see, this is getting pretty long, and our feeling is when you got more than about 20 things, 18 to 20 in here, it becomes less usable. I think this is too long personally, but I didn't have the knowledge or the confidence to say, well, we can divide this up a little bit and put it in different places. So, but again, down here I tried to thin out the information ones, essentially the handouts from the forms, but I did a pretty quick job, to be honest with you, and there may be a better way to separate these out. We usually would leave it to the doctor to do that. We would say, how do you want to divide these up? And we'd say, 10 to 15 is kind of ideal to have in a drop-down. Otherwise, it becomes less usable. But certainly, yeah, you could add local ones in here. This is where they would end up. Absolutely. There's no question about that as well.
Hi, it's Wendy. Can I just clarify, did I understand hearing, this is great, that the physicians could customize the list with local forms, like they could go in and, shorten or put the top four at the top?
Let me go into the back end here and just show you how this works. It's extremely simple. It's not difficult at all. There's this area called templates and forms, and this is where all of the forms are kept. So these are the ones in the ones you see first of all, which are the more commonly used ones. And again, this is fully customizable by the physician. And then we have these subfolders, and then you have adults and a bunch of forms, and then you have child and youth and a bunch of forms. Some people say, don't waste my time with mental health. I want adult mental health and child and youth mental health right at this level. Don't make me go down one level and go into these. It's totally flexible. In this, you can have 7 different folders if you want. It's entirely up to the physician, and they can put whatever documents they want in those folders. Now, where the documents come from, usually they come from our website. They download them and they save them wherever they want. If they're not on our website, they usually fax us a copy and say, can you make this form for us? And we do that, and there's no cost to it. And then we upload them into the appropriate folder for them. But they have complete control over the look and feel of what happens when they do this. Okay, again, what we try to recommend is you don't go too many levels down here, and maybe this is too much. Maybe they'd rather have one here, say adult mental health and child and youth mental health. I don't know. I've broken it out this way just to show that it can be put into folders, that's all. But yeah, there's nothing that we control here in a sense about what they put and where it gets put.
And no cost associated as well.
No cost, no. The only cost that would be associated, and again, I just want you to be aware, we are fairly new members of TELUS Health, so this policy, there may be a global TELUS Health policy that's different, but there's never been a cost other than if, for example, a company associated with mental health, whether it's a pharmaceutical company or something else, wanted a custom form created for mental health, physicians doing mental health, then we charge those companies for that form. Not the physician, but the company, and then we only upload it when the physician asks for it. We don't globally upload forms for any private company just because we don't think that's appropriate. But other than that, no, there's no cost to forms at all. No. So if the Kootenays has a special mental health program unique to the Kootenays or unique to Nelson and Rossland and Trail, then they send us the form, we create it, and then we upload it to those appropriate clinics and ask them where they want to put it. We've actually just gone through a whole process with many of our clients reorganizing all of their templates and forms, all of their documents to make them more efficient for them. Because sometimes the doctors it tends to build up and they ask for more and more, but they never kind of clean up a little bit, so we help them sort of do a little bit of tidying, a little bit of housekeeping from time to time.
I hope this answer doesn't put you on the spot, but is there a time frame? Just my last question, then I'll go back on you.
To get a form created? Is that what you mean?
In the example you just provided, a time frame.
To get from the time we receive the form till the time it gets back? Is that what you mean, till it's created and put back in there?
Sure.
Yeah, if there's a time frame for that, yeah, usually, well, it depends on the backlog, but usually it's about 10 days to 2 weeks. Yeah.
Thank you. It's helpful for our clinics. Thanks.
No worries. Again, if there's great urgency, we do it faster, but believe it or not, it does take quite a bit of time to create these and do it effectively, and they can be quite fiddly. One like this is pretty simple, but most of them do take a bit of time to get looking like they're sort of semi-usable. So I'm just working down here. I'm just getting to the SNAP 4 teacher parent rating scale. Now this is one that most likely would be printed out because it would have to go to the teacher through the parent probably, or maybe email from the doctor. But some of them would not be able to be, well, I guess the teacher could be emailed it and then they would fill it out online, but I'm not sure what the protocol would be to send that filled out form back over the internet. I don't know the rules around that. Okay. So if any of your clients, if we load these forms on their system and they say, oh, something is missing, then all you need to do is pick up the phone or have them pick up the phone and call us. So this should be in the information only one. This shouldn't be here because there's no form here, so to speak. It's purely informational. So that one should be moved to the information one, but I must have missed it. That's the problem.
Did they call you? It's Rob here again.
Yeah, just call us or email us. One of my colleagues here is called Kelly, and she does most of the forms. But if they just email support@oslersystems.com, then it'll come to me, and I just distribute them appropriately as needed. The odds are, Rob, that we already have the form, to be honest with you,
okay.
Because
and what's the number they call?
The number is 1-800-661-8066.
Okay, I have a clinic with regarding pain that couldn't find these and had trouble and still can't find them, even with talking to Kelly. So I'm trying to connect them somehow.
Yeah. So those are all the forms.
They can call you at this number?
Sure, yeah, that's fine, yeah. So those are all the forms. I'm not sure I need to show all these, Kelsey. I'm asking if you're, these are all basically handouts. They're not forms. So, for example, parenting overview handout is simply a handout that you would provide, okay? So they're not fillable forms. They're simply handouts. and they're all available. And again, we try to separate them out simply to reduce the size of this list. Now, again, physicians may say, you know what, I look at this list, there's, 30 of these on here. I'm only ever going to use 7 or 8 of those. But I don't think that's the right approach, right? It may be that they're used to using 7 or 8 of them, but in fact, if they go through the algorithm, or more likely through the actual encounter, they may realize that they've been using the wrong approach, and maybe a different approach and a different questionnaire would be better for them. So we're reluctant to remove these. We would just prefer to reorganize them in some way that made it a little less a little shorter if possible. And
again, if they put a number or something before them, will that put their sort of quick hitters at the top, like 1, 2, 3, 4, 5 or something like that?
I'll just comment to that, Rob. Thanks. That's a good question. Yeah. You see, what I've done here, I've sort of cheated slightly, is all I've done is I put a hyphen before the 3 that are used the most up here. But yeah, you can do, some people do 1.2.3.4, and that moves them up to the top, or they can use a hyphen or some character that takes away the alphabetization, blah, 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 sorry. But yeah, otherwise they're automatically going to be in alphabetical order. So to get around that, you use numbers or hyphens or some way to move them up to the top. You absolutely can do that, and it will reorder them in the appropriate order.
So this is something they can actually do themselves if they know how to do it, or they'd have to call you to do that for them?
Yeah, they can, but it makes me a bit nervous, but they can certainly go in here and say, I want this support plan, I want to rename it, and I want to put in 1 period space here, and I want that near the top. And then I can, do, so the 1 goes up to the top below the hyphens, and then I want this one to be 2, or I want the PHQ9 to be 2. Yeah, they can do it themselves. Again, it makes me a bit nervous, but certainly they can do it. To be honest with you, they can't really, the worst case they can, the document vanishes because they rename the extension or something, and in that case they just phone us up and we put it back in there, and usually at that point we start to help them out with it a little bit. So I'm not adverse to them doing it. They can actually get to that from inside the program. If they go to Documents and into Browse, this jumps into the back end of the document, and they can go into their templates and forms and modify them if they want to. So yeah, they can do it themselves. Certainly they've been given instructions on how to do it, but sometimes they prefer to call us and we help them out with it.
Thank you.
So those are the mental health forms. Have you got any questions at this point? Is there something obvious that I've missed?
David, it's Wendy. Thank you for this. My screen maybe wasn't showing all of your steps. And can you just go back to, from the beginning, you went into the patient and then you went to encounter and then document, or?
Yeah, you have a choice, Lindy, at either one, really. So certainly you can do the whole thing through documents, and the benefit of that is that if you save them appropriately, all of your mental health related documents will be in a single folder, okay? And that's convenient if you need to send those out to somebody else. If you decide this patient needs more care than you're able to provide, you can send that package out. You can use encounters for some of the things, for sure. Not all of the things, because documents lend themselves better to auto-populating than encounters do. So I think if somebody asked me what would you prefer, I'd say I would use documents for all of them. So again, with the mental health and the adults, okay, they can start with the, the algorithm if they want, or they can start right away with a PHQ9 and open it up and run through the PHQ9 and get the score, and then from that score they can decide, I'll put them in the bounce back program, I'll refer them here, I'll do this, I'll prescribe a med, or maybe a combination of all those things. And then probably the last thing they do once they've done all that is they would do the mental health plan. And all of these would then get saved into this documents area. So I've got the PHQ9 here for her, which I've scored. And then I've got the mental health plan, sorry, that just opened up because I left it open at the bottom. And then I've got the mental health care plan here, okay? And I've got the bounce back referral in here as well. So here's the mental health. Now I didn't fill this out. Obviously you would fill it out a little more comprehensively in most cases. And then I've got the bounce back referral right here, which I would then send out to my staff member to send off. So I personally like the idea of gathering documents together better than blending encounters and documents. That's my personal preference, and I think that's what the clients who use these features actually do in most cases.
Hi, David. I'm just noticing here you've got, so 2 PHQ-9s done. One was a score of 19, one is a score of 22, so it's 2 different encounters. Is there a place where you can look at that, just the PHQ-9 trend? Probably a different question, I know, but is this where they
it's a good question. Not really. The only way you can do it is actually just to do it this way. To see them here together, you just click on this and it sorts them all, puts them together. Some people do put the PHQ-9s in a separate folder under mental health. So I can actually create even a subfolder here called PHQ-9. Is that the right thing to do? It's up to them really, but you can isolate those out if you want to, and then you can see it more simply because they're all together and there's nothing else in there. So there's no other way. Unfortunately, we don't give you the ability, which would be really nice, to graph these, which I know some EMRs do.
What happens if you hit graph now? Does that do anything or no?
Doesn't do it. No, you can't graph a PHQ-9 score. We don't. I've seen MedAccess a lot the last month because it's one of our programs, and you can actually put the PHQ-9 under something in MedAccess called vitals, which essentially, we consider measurements like blood pressure, but vitals for them is a broader category, and I've seen them use vitals for PHQ-9, and then you can graph them and put them in a table. We don't at this point have that ability. I think we may add it, but at this point it's not, you can't graph or put in a table the PHQ-9s.
David,
yes.
For this form, if you, particularly for the PHQ-9, if you enter the content through encounters versus through the document, does Osler save it differently? Does it use that data differently?
Doesn't really use it differently. No, not really. The data is still there. In either case, of course, in a document, it's not fielded data, right? It's not in the database somewhere where the PHQ-9's total score is 22 or 19 because it's a Word document. Essentially, it's an image, right? Essentially, it's a picture with a number in it. With the encounter, you do have the ability to look at those. And that's why we put these scores in here, because that essentially allows us to treat it as fielded data. Right? I could put just 22 or 19 here. We do the score equals, and then I can filter these things out in a custom report and say, show me all my patients with PHQ-9s over 15. The protocol has changed. Anybody over 15 we need to send to this program rather than the programs that we're sending them to now. So this essentially becomes my fielded data. That's kind of the workaround we use to make it fielded.
So where does the data go if it is entered in encounters?
Well, then, if it's in an encounter, I think I've got one here. Yeah, here we go. If it's in an encounter, this total here is, again, anything in encounter that you add, this all goes into the fielded data in the database. And you can then generate, essentially, custom reports based on any of these discrete values. Okay, so whatever this happens to be, I can generate reports, right, based on this because this is fielded data. What I can't do in the Word document that I could do in here is I couldn't say, and this is pretty unlikely I think, is tell me everybody that answered the question feeling bad about yourself with a score higher than 2 in the last 6 months. I can do that with an encounter. I can't do that with a Word document. Again, pretty unlikely I think that would ever be done or required, but that's the benefit of an encounter as opposed to a Word document. And again, the worker.
Can you go back to this report? Oh, so that's where that is saved?
Yeah, it's an encounter basically. It's where a doctor and a patient come together in some way. That's all it is.
Okay.
Again, what we've tried to do to try to mitigate that is to use this method here. This method allows me to track the total scores, not by a graph or by a table, but again, I can write a report and say, give me everybody with a PHQ-9 over a certain amount in the last 3 months or 6 months or whatever. And we actually had one doctor got audited on it, a college audit of some kind, not a financial audit, to show that it was a he in this case, he was keeping track of the patients who were had PHQ-9s and they were being treated accordingly based on their score.
Thanks, David. I appreciate it.
No worries. Okay. Any other questions?
Just Rob here again. If we're working with clinics on this, and they ask, or just so we know, I guess, so with our support, how has this been reviewed by GPs so far? Has this been vetted through anyone, or are we kind of at that test phase right now?
Yeah,
as far as, I guess.
It is used. I mean, I can't give you percentages, Rob. We don't get a huge amount of feedback. Probably the biggest push for it came after, Kelsey, you remember this, the meeting last year at the Wall Center. And after that, a lot of the doctors who attended that in different roles who were Osler users phoned us up or emailed me and said, can you dump that into my system? And I think they use it. We don't really keep track of those things. We, usually on a support desk, you hear the bad news and the problems. When you don't get any news, it generally means either they're using it well or potentially they're not using it at all. And we haven't certainly done a survey based around mental health, so I really couldn't tell you how well accepted it's been. I really don't know. And Kelsey would have a better idea about the global uptake of these forms and how well they're working in the broader physician population.
Yeah, well, we haven't put any provision, like we haven't said, like to the vendors, can we work with you to get some, anonymized sort of stats back on usage, but in theory, we might be able to set that up with various vendors to look at rates of access or times of use or things like that. And as you know, it's not necessarily a requirement that we have as part of participating right now in our modules, although, that could change, that could shift depending. So there's nothing imminent right now. We are.
Sorry, I'm just wondering, are there any GPs on the line now, or has Dr. Hobson reviewed this, or anything like that? So as the part of the approach for this, and in terms of writing the requirements and so forth, was very much had physician feedback. But I think there's always a bit of a learning curve. So what we tend to do is, as you know, a lot of our content is quite new into the EMRs, and how it's structured, the workflow and things like that. I mean, we get a ton of feedback, and a lot of it is what I would call personal preference type feedback. So the things that David was speaking to around the ability to, I think, customize lists or things like that is going to be key. And for, in your role, to be able to speak to what those options are in the various EMR platforms will be really helpful, because a lot of our modules have a lot of information that we know isn't going to all be used, but, they might latch on to a handful of key forms that they really take away or decide to, kind of embed as to part of their practice or workflow. So I think that it's going to be that ability to be customizable, because if you, I kid you not, I'm using pain as an example, but I've had multiple emails that are or feedback from physicians that's just completely contradictory. Well, physicians wouldn't do this, but in another email, another physician is completely contradicting that statement. So it's personal, and I think that as long as we continue to give that feedback and the EMRs can remain customizable to some degree as it relates to setting up the workflow or hiding things that maybe they don't want to see all that often. But as a provincial program, of course, our interest is to make sure that all of the content that we teach to is available. And so that's why you see this massive list here that David's shown us, because from PSP Central's perspective, it is important that we put forward everything that possibly could be covered in a learning session.
But Kelsey makes a great point. If I'm a doctor and I see this list, I'm shutting down right away. I'm saying, don't, you must be kidding if I'm going to look through all these. So I think her point is well taken, is that, yeah, you'd like them to use all the resources that are available to give their patients the best possible care for mental health. But maybe you say to them, well, let's put the most important 6 on here to start with for you. We'll put in the PHQ-9, the Too Scared, the CADS, whatever it is. We'll put no more than 8 on here to give you a head start. You may not be treating your patients quite as comprehensively as we'd like, but it's a starting point, and as they get more proficient and more confident and hopefully see good results clinically, then you can add more in here. This would be, quite frankly, a crazy list to give a doctor just starting out with child and youth mental health. They would give up on it right away. I would give up on it right away if I was a doctor. It's too big. There's too many choices. So I would start modestly and then build it out as they want to use more options. Certainly in terms of use, we can easily run queries behind the scenes and do quite often on our sites, anonymized, to say how many PHQ-9 questionnaires are saved in our top 100 clinics, and we can find those numbers out in no time. And we do from time to time. I don't think we've done that one, but we certainly do. We've done it with the pain management. It's quite easy to figure out behind the scenes how many times something is being accessed or used or saved. That's really easy to do. That's what obviously technology makes it easy to do.
Hi, it's Wendy. And yeah, thank you. Speaking in terms of customizing, my earlier comment, top 4, et cetera, you could go even further and like global assessments, anxiety, depression, and ADHD, if we're speaking in the child and youth folder, just to help physicians not see that glare, and as they, use it in their workflow, maybe just breaking it down even further. But then I guess that would require, 1 is, global assessment, 2 is anxiety, and 3 is depression, or you know what I mean, like numbering. I don't know everything. Number 1, number 2, number 3.
That's not difficult to do. Again, they have full control over that, and we help them with it, obviously, but they have full control, right? So again, you could base it on this, right? You could put the forms in here. If you answer yes, you go to the CADS evaluation and go this way. And if you answer yes here, you go to this. You could put these in different folders if you wanted to. So based on if they do this to start with, which is what is recommended, then this would direct them to the different areas depending on which question they answer yes to. So there's no right or wrong. You're right. It could be based on the diagnosis, the type of mental health issue, or it could be based on child and teen. It just depends what you want. We wouldn't recommend you go, 6 levels deep here, because that just compounds the problem vertically rather than horizontally. But there's really nothing they can't do in terms of organization, either horizontally or vertically, that they want to do, either with dashes or numbers or different folders, subfolders off here. Okay. Lots of flexibility being built into it if that's what they want. But again, I'm of the opinion really that I would only give them a few forms to start with and get them used to using those few heavily used forms, and then start to fold more in as they, you can have all the other forms here in a subfolder, but only have, whatever, a small number up here to see if they use them. And then if they really need the other ones, there can be subfolders with all the additional forms in there. So I don't know, for example, how often the craft screening interview is used. You folks and you know that better than I would. Maybe that's hardly ever used, and maybe that belongs in a subfolder and not on the main list. I don't know.
You could go with the 3 questions, and the 3 mental health kind of universal questions from the beginning, like how we were trained with the PhD content, and then based on that, just having minimal tools available, like the CAD6, and, SCARED and the SNAP tool. You know what I mean? Just to get them used to utilizing those tools, and like you said, a subfolder, but just keeping it simple. Yeah.
Hi, this is Joe. I just wanted to say that the list, yes, the list is long, but from my experience, it was very timely while we were doing the child and youth mental health module that the tools were available in Osler with a clinic that I'm working with, and it was really nice to actually be in do the practice visit and be able to just, at a glance, even though it's a long list, here they are, this is where you can find them. I didn't know that they can be customizable based on what the doctor wants to do. I think that's a really good point. I still think, I mean, we can recommend whatever we want. It's basically up to them how they want to do how they want to do it. But it was really nice to actually have them there, and the doctors kind of could, from having come to the session, they've heard it at the session and they've seen it in their EMR, and it was a really nice practice visit because they were opening it up themselves and looking at it and figuring out a good workflow around the tools. So I advocate for them all being there, and then the doctors can decide themselves how to customize it.
Right. Yeah, I agree. Okay.
Yeah, that's great, Joe. I agree.
Okay. Well, I think that's it. Thank you so much for your time. I appreciate your questions. It always makes it better, and I will definitely add that CDIS Adult Skills one as soon as we can find it and do whatever needs to be done. And other than that, if you're seeing any Osler clinics and they either don't have this or it's not organized in a way that is functioning well for them, then give us a call or an email, and we will we'll call the clinic up and take care of it.
Do we have your email, David, or just use the support email?
And just use the support one, and then if I happen to be out of the office for a few days, it's not going to rot away somewhere in a corner. So just use the support one, and then I can distribute them appropriately.
Okay, great.
Okay, well, thank you very much.
Thanks, David, very much. Thanks, everyone.
Thank you.
We'll send the recording out shortly, so you'll be able to reference back.
Thanks.
Great.
Thank you.
Thank you.
Thanks, Kelsey. Appreciate
Thank you
it.
very much.
Thank you. Bye-bye.